So I know people are still kind of milling in, but I will get going with our introduction. Tonight we'll be talking about the basics of scleral lens troubleshooting. We have Dr. Paymaun on, and so excited to have him. So Dr. Paymaun attended the University of California, Berkeley School of Optometry and graduated in 2018. He works in his native hometown of Sacramento, California, where he owns a private practice about to come up. You said in year three?
Yes.
Awesome. Where his office emphasizes especially contact lens, full scope myopia management. He is a fellow of the American Academy of Optometry, as well as fellow of the Scleral Lens Education Society. Speaks and publishes on material on especially contact lens and myopia management. He has served as president for his local optometric society in Sacramento and currently a committee member on the Children. Here are his financial disclosures. So throughout the presentation, whenever you have any questions, go ahead and enter it in the Q&A feature. Some questions we might try to get to during the actual lecture, but if not, that last 10 minutes will be reserved for answering as many questions as possible. Keep in mind for the CE credit, you got to stay on for the 50 minutes. You don't have to stay for questions, but I do find that's going to be a very fun part, just finishing up the lecture there in that last 10 minutes. The course handouts will be found on the SLS website library page within a week or two afterwards. And if you don't have the OE Tracker app, you can download that. And at the very end, after we finish everything, there will be a QR code that you scan, and then it will help log your CE. If you don't have that, they'll still be emailed you in 2 weeks. Without any further ado, I'm going to stop sharing my screen and carry it over to Dr. Payman. Thank you so much for being with us.
Thank you so much, Dr. Skidmore. I'm so excited to give this talk. So let me just get my screen share going and start showing my slides. Give me just a moment.
And he also is going to have a couple of QR codes to do some polling questions. So I don't think I need to tell anybody to keep their phones nearby, but be ready for that.
Okay, can you see my screen?
Perfect.
Okay, and you can still hear me okay?
Beautiful.
Okay, well, hi everyone. My name is Dr. Paymaun Asnaashari. I'm so honored and humbled to be here to give this talk on the basics of scleral lens troubleshooting. I'll start the next slide to kind of go over a little bit about me. So I find myself in a unique position to be in this talk. I felt when I finished school, I was probably not going to ever probably be in this type of position to talk about scleral lenses because in 2018, I graduated from school. And then actually in my last year, I actually had no interest in specialty contacts. I did not do a contact lens residency. But something happened a couple years later where I was working multiple jobs in different settings, from private practice to ophthalmology to retail optometry. And then in 2020, during the pandemic, a unique case just presented to me, and I had a scleral lens fitting set from school, but it just kind of collected dust, and I never used it until this opportunity in 2020 when a post-LASIK ectasia patient presented to my chair, and it was just, she had just really bad vision and just wanted something to be able to help her see. And I just remembered I had this scleral lens fitting set. And, the office I worked at, we didn't have any advanced, topographies or any topography at the time when I started and any other advanced equipment. So I was just literally fitting it empirically. And it really just, I underscored that it pivoted my career after having success with this case and made a transformative impact for this particular patient. So this was the starting point of my scleral lens career, was a couple years after school. And so I find myself in this position giving this talk on a very, prestigious platform with a bunch of other fellows and people that I admire. And so I feel very humbled to be in this position now to like give this talk. And I've been fortunate to have lots of referrals now in this office that I took over. And after this case, I just started to want to chase more of these type of fits and chase more scleral lens fittings. And, when I took over this practice in 2022, this office was very basic and we didn't have any specialty lens experience in this practice. And I had to essentially start from scratch and to build a clientele to fit specialty contacts and do full scope myopia management. So I've just grown to have a huge passion for specialty contacts. It took me some time after school to figure it out, but I still feel very lucky to be able to do it. And now we're fortunate to have lots of cases of scleral lenses and myopia cases in our office. So that just shows a little bit about me. And for any of you that, maybe are in a similar situation like me, your interest might change after school. As someone like me, I did not have an interest, when I finished school in specialty contacts, but along the way, life gets you experiences that might turn your page a little bit in a different direction, and then here I am now. So, anyhow, nonetheless, I'm super excited to give this talk, and hopefully, if you can take one thing that's valuable from this talk, I hope you do. Otherwise, we'll go ahead and get started. So here are my financial disclosures. And then I'm going to first open the slide here with just some objectives for this talk. So three main objectives. We're going to identify some common issues with scleral lens fittings, identify causes to them, and hopefully learn some solutions to implement to help address these common issues. So how many of you seen this? Multiple different types of fitting sets. This is what I was dealing with when I first saw this patient of mine in 2020. I got this case. I had no advanced imaging, no profilometry, no topography. I just had this and some fluorescein. And so when you're fitting patients with scleral lenses, I think it might be a little easier to pick what size to grab because we have access to measuring horizontal visible iris diameter and specifically HVID. But I think picking the right sagittal depth to start was so tricky to me to start. I would oftentimes just grab a lens, just put it on the eye, and there's nothing wrong with that. But I think from fitting patients for a while now, I find that it's a little bit better to have maybe have a little bit of a better understanding of what sag to pick before. So hopefully you start at a closer endpoint. So hopefully it makes you more efficient and less likely to maybe have multiple visits of many small adjustments. So I think hopefully with these next set of slides, hopefully you might have a better idea of what lens to grab out of your fitting sets. And I'll lead with a poll question here. So there's going to be, I think, about three poll questions throughout this talk. So I'd encourage you to participate. All you need is a mobile device, and you just need to scan this QR code, and you should be able to easily participate. So I'll go ahead and open with this question. And the question is, if you are fitting a normal cornea with a scleral lens and you want 300 microns of starting central clearance, what starting sagittal depth would be ideal? And I'll give about 10 to 20 seconds or so for people to kind of pull in and take a good guess. There's really no right or wrong answer, but I think hopefully this will get your mind thinking a little bit, and we'll see how people do. Awesome. Well, I appreciate the participation. Okay, it's pretty good. So a lot of you have selected the first choice, which is 4,300. That's certainly not a bad choice. So I think once we go through these next slides, you might be surprised, is 4,300 the most ideal sag height for a normal cornea? So we'll go next to these next slides. So these are slides that were from the Pacific University. It's called the Scleral Lens Shape Study. And they essentially looked at the sagittal heights between normal corneas and patients who have keratoconus. The ones that are annotated in green are normal corneas, and the ones annotated in red are keratoconus patients. And so if you look at the sort of graph here on the left side, this is essentially taking sagittal height measurements from the base of the cornea, which is the 15 millimeter chord, and this is the 10 millimeter chord. So from about base level to the mid level of the cornea in a keratoconus patient. The average sagittal height is about just under 2000 microns. And if you look at in normal patients in the same measurement, it's about the same. It's just under 2000 microns. So from the base of the cornea, almost where we measure HVID to the mid-level of the cornea, the sagittal height is actually not much different. So, and then if you look at the right side, where you look at from the mid-level of the cornea to the apex, we know that in keratoconus that the apex protrudes. So it's no surprise that you'll see a little bit of a difference. So in keratoconus patients, the sagittal depth is about almost 2000 microns. And then in normal sort of corneas, it's a little less. It's about 1750. So the main difference in sagittal depth happens more so from the halfway point of the cornea to the apex. And so in this next slide, it's going to sort of break it down a little bit, I think, easier to see. So these are kind of the same slides, but just organized between normal corneas and keratoconus. And we're just showing the average sagittal depth between normal corneas and patients that have keratoconus. So if you look at the top half where normal corneas are, the average sagittal depth is about 3,735 microns. And that's essentially just these two numbers added together. And in keratoconus patients, we would expect the sagittal depth to be larger. So the average in keratoconus is about 3,930. And again, in keratoconus, the condition is progressive. So, the sagittal depth may not exactly match this. But again, these are just sort of average numbers. So you have an idea of what the sagittal depth is. So if you're looking to just pick a lens out of a fitting set and you're trying to just fit a normal cornea, and if you want 300 microns of central clearance, this sort of slide will kind of break it down here. So what starting lens size should you pick in normal corneas? So if the average corneal sagittal depth in normalized is about 3750, if you want a starting central clearance of about 300 microns, you should grab something from your fitting set that has a sagittal depth of 4050. Now, on the poll question, most of you selected 4300, which is where I was kind of thinking you might select, which is not a bad answer. But in that patient, you're going to have about 600 microns of excessive clearance when if you knew what the average sagittal depth in a normal cornea was, you might want to grab maybe something closer to 4,000, which will put you closer to your endpoint of where you're looking to be. And again, there's no right or wrong answer of what, lens to select, but this can put you in a better spot. And then in keratoconus patients, it's a little different. And so the average sagittal depth in keratoconus patients is about just under 4,000 microns. And if you want 300 microns of starting central clearance, you should grab something closer to about 4,300, where most of you selected. So, and again, the only way to measure sagittal depth accurately is if you have an advanced anterior segment imaging machine, whether it's OCT, topography, tomography, where you can actually measure it. It's not necessary to measure, but this is just showing you some averages. So hopefully you can, start at a closer endpoint in terms of getting a better idea of your central clearance. But otherwise, this hopefully can give you a better starting point when you're just starting with a new patient. The next troubleshooting that I think we don't talk about enough is the INR. And I get stopped on scleral fittings a lot because of challenges with insertion. I mean, this is probably of all the specialty contact lenses that we have access to. I still find that this is probably the most difficult lens for patients to insert. And when I see a patient that watches my video that I've made on YouTube on how to insert and remove lenses, this is kind of the look that I'll probably get. They'll have this like crazy look and they're like, this is how you do it. And, if you have all sorts of cool toys with profilometry, impression-based methods, topography, and, you can design the most beautiful lens, but if they can't get the lens on, that's going to stop you from being successful with that patient. So we'll go over some reasons why we run into trouble with INR trainings and hopefully share you some solutions that could be used to help and make it easier for your patients. So here's some main causes that I've found, at least with INR training. So number one is age. I'm not sure why, but my clinic tends to attract a lot of presbyopes that are new to contacts for scleral lens fitting. So I get a lot of people that don't have good near vision when they're entering, and you're working at such a close working distance. So age tends to be a big factor, I think, when it comes to INR training. Secondly, I tend to ask this a lot during my exam is, do you have contact lens experience in the past? Because if they do, I think that certainly can make it easier on my staff or myself with insertion. Touching their eyes, getting used to manipulating their eyes in the past can help make it easier so they don't jump out of their chair when we're trying to put the lens on. Also, this lens requires a face down position. I don't think there's really any other lens that we fit that requires a face down position. And I've had multiple patients where they've had back surgery, neck surgery, they're elderly, and they can't put themselves in a completely face down position. So I think this can be a huge challenge and a reason why there can be issues because it really requires that face down position. So, and also another thing I look at is what is the maximum opening of their palpebral fissure? Some patients' anatomies will allow them to open their eyes really well. Some other anatomies or ethnicities are definitely more narrow, so you can run into trouble because you definitely need to get this lens, the eyes open enough to be able to successfully insert. Another challenge that can come up is deep set eyes. It's much harder to open the upper lid and lift the upper lid when they have deep set eyes, at least when I see patients that do. So that could bring a challenge. Also, some patients are just highly sensitive. They're not comfortable manipulating their eyes. And as soon as they feel the saline when they're putting this lens on, they jump out of their chair like a volcano, and it makes it that much harder to insert. So it might go a number of rounds of training, could require multiple visits until they get settled with the way we insert these type of lenses. Another one that I find also a big challenge is Bell's phenomenon, which is a reflex where the eye under sort of stress will just rapidly move in a direction. Typically, it's in the upward direction. I have a patient the lens fits great, the vision is great when it's successful, but he has such a hard time getting the lenses on without bubbles because of his Bell's reflex. And if you see a patient that has a Bell's reflex, one way you can kind of try to help is to follow the motion of the direction of their eye while you're trying to applanate the lens on. So for this particular patient, while they're facing down, I am instead of going from down to up, I'm going from down to kind of a C sort of pattern while I'm inserting it. It sounds very unique. You kind of have to do it rapidly because the Bell's reflex is rapid. And that helps, at least for this particular individual that I have, made it much easier to insert without bubbles, but he still actually has a lot of trouble following his Bell's reflex. But that can present challenges to INR training. So look for Bell's phenomenon. So some solutions you can use. This is a video that I made for my office, and I have every one of my staff and even patients that I'm fitting lenses in watch this video. And so I took a lot of time to make video for scleral lens insertions. There's a lot of great videos out there on YouTube and online that are available. But I felt I wanted something very concise, specific, that also goes over recommendations with insertion and removal. So this is about a 6.5 minute video. I would encourage any of you to watch it and use it with your team members, use it for your patients. I think it hopefully walks you through on how to insert these lenses from start to finish with a lot of tips and recommendations. So just have to type our business name. It's called Art and Park Optometry, and you'll be able to find our YouTube channel. So this is actually on my video. This is a screenshot from my video that I made. I actually learned this, and I would give a shout out to Dr. Heidi Miller, who also practices in my area, and she told me about this when I forget, this was probably I don't know, maybe 5 or so years ago, when she says she uses a funnel to help with insertion, and I thought this was kind of crazy. It sounds really interesting. This is just your average, home goods store funnel that you can buy. It's really inexpensive, and the diameter of scleral lens inserter tools fits so perfectly on the tip of these funnels that it acts like a stand. And when you have patients that have challenges with holding the lens, getting it in position to be able to insert, I find that this can help tremendously to make it much easier to get it on so they don't have to physically worry about holding the tool. So if you're having difficulties with insertion, having some type of stand and a simple funnel like this will work very well. So I have a video here. It has some sound, but it's not crucial for you to hear the sound if you can't have it. It's just going to show you how this funnel sort of works in my office. So I'm just going to play this and hopefully this will work. This is going to show me moving down while it's on the funnel. So makes it really easy. You now don't have to hold the lens and it stands up in air a little bit. You don't have to move so close down to the desk. But again, it's a simple way to use. There's also now lots of other stands that are out there, and I'll show you some of them. And so let's go to the next slide. Okay, so here's another stand that's available out there. This is made by a company called Seagreen. This has a stand, but it also has an illuminated light source in the middle, so it makes it, I think, easier to look at the target and keep your eyes sort of locked on a particular lightable device. So this one comes at a price point. I want to say I think this is several $100s, but I have a few patients that use this and really like this. So this is something that's available that's out there. Another option is this. This is made by Augmented Vision Labs. This was designed by an optometrist. And this is great for those that want to kind of stand up. It has sort of, they make a few versions, but this is the one that's the standing version. This also has an illuminated light source, and it works really well. This also is several $100s, but I think it's a really well-designed stand and could be valuable to your patients that have challenges. Here's another one. This is made by the same company that makes the scleral lens tools, DMV. They make a very sort of simple stand that you can break apart and you can travel with it because it disassembles. So it's a very simple stand. I have clients that we use and this is very inexpensive and it can make it much easier to use. It's very similar to the funnel. The funnel, unfortunately, is kind of bulky to travel with. This is, again, you can break these pieces apart and it makes it super easy to travel with. So this is another option that you can consider. This is called lens based. This is a small portable based stand that is really valuable and really compact. So something that can fit in your travel bag. And this is also inexpensive. But this is another valuable tool that's out there to use. I have never used this, but I have seen this around. This is the Easy Eye Scleral Ring. Again, this is not an expensive tool to use, but I would say this is another option that you can consider, which kind of puts the lens on this ring, and it could be another alternative if you want to try something else. But I have no experience using this, but I know it's out there. So here's some tips for removal. So if you're having trouble with removal, one of the quickest things you can do is to moisten the removal tip. If you moisten the removal tip, I typically recommend using preservative-free saline. It just makes the tool more stickier to the scleral lens, so it just grabs it better. There's a capillary attraction, and then I think that helps to remove the lens better when you have like a tight seal. Also, what also can be valuable is instilling preservative-free artificial tears into the eyes to loosen the scleral lens. I can't tell you how actually this valuable this is. So if you get a patient and you're putting the lens on, or if they feel like they're pulling their eye out, you should actually insert some saline into the eye, and that will help loosen the lens up, I think, pretty noticeably to get the lens to pop off easier. You can also, when you applanate the remover tool on a scleral lens, you can try to rotate it a little bit clockwise, counterclockwise, and then this will help to break the seal of a tight scleral lens. So you can try rotating the tool once it's applanated to help. The next common troubleshooting thing I guarantee that you'll experience at some point in your scleral lens fitting career is air bubbles. And this is just me in my video showing a big air bubble that's formed during the insertion. So you will see this at some point in your career, and this can present a lot of challenges. So here's some causes to why bubbles form. Number one, it's usually due to an insertion issue. Either it's a technique or they're not centered on the eye when they insert, and then it creates a bubble. Secondly, it could be due to insufficient saline. That's another big issue why. So make sure that when you are having patients that are having persistent bubbles, educate that they really need to overfill the lens bowl so that way there's no air remaining in the vault system. If they're not filling the lens with enough saline, there's going to be residual air in the vault system, and that's just going to create air bubbles to get in and form. Another issue that will bring up air bubbles is blink reflex. This lens is going to induce a reflex of blinking when they put it on, and that subtle amount of blink can slightly move the lens as they insert it. It can tilt it, dump out saline. So getting the blink reflex under control is really important to make it smoother with insertion and hopefully reduce the chances of bubbles. And again, Bell's phenomenon can certainly cause bubbles because that movement of the eye moving rapidly up, and if you're going just straight up, that lens is not going to be centered when it goes on. And so it's going to tilt when it goes in, and it's going to spill the saline, and then it can create just air as it goes in. So if you have patients with Bell's phenomenon, I would encourage just to go in a C-type motion up instead of going from down to up. Just follow the movement of the eye up, and it makes it much better to remove the bubbles when you insert. Here's some other solutions for addressing air bubbles. Number one, review INR. That will be the biggest sort of reason why that bubbles are typically happening. It's usually due to insertion removal training. Again, you want to fill the lens bowl completely, ideally overfill it. You want to make sure you push the lens all the way onto the eye because if you're not, that lens is not going to settle and applanate, and then it could induce some air as it goes in. Here's just some simple tools that I've found patients use. One of them is recommending high mag mirrors, specifically around the 10x range, especially for those presbyopes that, they can't see the bubble. And so this is a demo mirror that I've had patients buy. It's made by Avanova. It has an illuminated light source, so it helps to see with better contrast. So I think having some type of high mag mirror for anyone, especially your presbyopes, to make it easier to find bubbles when they can't feel or see that it's hard to see it. Another one you can do is offer in the beginning phases of your trainings, is to offer sodium fluorescein strips and have them get a cobalt blue light that's portable, or if you have one willing to spare, you can give to your patients that are having more challenges with bubbles. It just will help to identify bubbles quickly with using that cobalt blue light. So it's something you can consider doing if you wish. Next troubleshooting thing we're going to run into is lens discomfort. And I find that this discomfort comes in two forms. It's either on insertion or it typically happens as the day goes on. So when a patient presents this, I will usually ask them, is it right away? Or is it as you just wear the lens longer? So I think this will be a good question to ask when you have patients that report that it's uncomfortable because it can help identify what the issue may be. So, and we'll go over some reasons here. So here's some causes for discomfort on insertion, and it could be due to bubbles. Bubbles will make the lens unstable. It may not make the lens fit well. It might excessively move on the blink. So just make sure that you're not seeing any bubbles. Secondly, why you could have discomfort is actually the lens is moving a lot. I've had multiple patients where we put this lens on, it's moving as much as a soft lens or more, and that's not ideal in a scleral lens. So check for excessive lens movement. That could be a big reason why. Also, if you put these lenses on and they're not centered and they're off the eye, that'll immediately cause some immediate discomfort. Could also be that there is absolutely no touch, or there's complete touch, excuse me. So like if you grab the lens with an inappropriate sac height and there's complete touch, there's going to be frictional forces. So it could induce some discomfort right away and could be due to excessive edge lift. The landing zone of scleral lenses could have too much edge lift, and it could cause the lids to rub against it as they're blinking in it. So that could be a reason for sort of immediate discomfort on insertion. Also, past eye surgeries, specifically scleral buckles and pterygium removals. I've had a few patients that we fitted and had scleral buckle procedures done, and we know that with the buckle procedure, it's going to alter the shape of the sclera. And I've had patients where the vision is great, but the lens is not fitting well. And it's because the scleral shape has changed from the surgery. And so sometimes having some more advanced technology to fit a more custom designed scleral lens, like profilometry, impression-based methods, could sometimes be more ideal in these cases when they have just a more unique scleral shape. Even in pterygium excisions, the alteration from the surgery can create areas of the sclera that are not particularly normal. And so it might cause the lens to not completely land appropriately. It can create some challenges with discomfort. So I had a patient once that had scleral buckle procedures done, and the lens looked decent. It wasn't fitting particularly well, but the vision was fantastic. But ultimately, we had to stop the fitting because we couldn't get a lens to successfully fit on her eye well. So it was just an unfortunate case, but after that case, it highlighted the challenge that patients who have scleral buckle procedures can present. So just look for those. And so if you get less lens discomfort as the day goes on, here could be some causes for that. Number one could be impingement. It could be a tight edge after settling. We need these lenses to settle, and so that impingement can start to show up the longer out that they've been wearing the lens. Could be due to edge lift. As we know, the edge component can be changed as the lens settles more. Could be due to excessive lens clearance. We know that transmissibility of oxygen could be different when you have excessive lens thickness or excessive saline under the lens. So this could cause some discomfort as the lens is worn for a longer time. So check for excessive central clearance. You'll also want to check for central and limbal touch after settling. When the lens settles, the central and limbal areas could change in clearance as they're wearing it more and for longer periods of time. So just make sure you check the central and limbal areas. Could also due to be minor conjunctival lesions like pinguiculas, pterygiums, chalasis. So, these type of lesions can cause the lens to not, sit particularly evenly across the whole sclera. And so you just want to kind of look out for these to see if you may need to make some adjustments to have the lens better sit better to reduce some of the discomfort issues. Could also due to be front surface wetting, patients who have an ocular surface of the lens where it's having a lot of deposits, that can create lens discomfort. It can lead to vision issues. So, you want to address front surface wetting issues if it presents. Also could be due to ocular surface disease. There's a lot of patients that we see that have potentially forms of ocular surface disease, and so you want to look to identify it or potentially address it while you're fitting these type of patients. And if they're complaining of lens discomfort as the day goes on, look for ocular surface disease. It might be something that we may need to manage as we're fitting this lens. So here's some photographs that I took of some patients who actually complained of discomfort. So the photograph on the left side here, this is a patient who has a prominent pinguecula, and you'll see here that there's actually some shadows up here. It's very subtle, but if you have a bright light source, you'll potentially be able to show it, and if it's at the right angle, you'll be able to see it. So you see that with this patient, there's a slight shadow up here above the pinguecula and even a little bit one down here. So this edge is a little bit lifted from this prominent pinguecula. And this pinguecula doesn't look that prominent because it's a 2D image, but in 3D, this pinguecula was quite moderate in size. So it just caused the lens to vault a little bit on this edge. So we had to make some adjustments with adding some notches to be able to get this lens to land a little bit better on this area, on this side. This photograph on the right is a little bit harder to appreciate, and I had such a hard time getting a really good photo of what I wanted to show. But this is a patient who's done RK, and there's fluorescein in it. It's really hard to appreciate it, but you might be able to appreciate the subtle green that's in this lens. And this is highlighting the central clearance, but this patient, there was enough central clearance. It may not look like that, just the photo quality is not ideal. But as you get down to around the mid-peripheral parts of the cornea and even to the limbus here, there was complete touch. And it was hard for me to see the touch. So it's sometimes good to just go down to basics and put fluorescein in because it's really nice to have advanced imaging and it becomes valuable at times or a lot of the times. But your simple fluorescein can help so much. And so, when this actually patient on the right, complained of discomfort as the days went on. And so when I started to look at things more carefully, I noticed that there was no clearance from the mid-peripheral parts of the cornea down to the edge of the limbus. And it was kind of like this circumferentially because this she had RK and her central cornea was flat, but her saline thickness was uneven from the center to the edge. So we had to continue to redesign her lens to be able to get this, clearance to form. And then this next picture will show you what her eye looked like when we took the lens off. So after the lens settled, we looked at the lens with fluorescein again, and you can clearly see that there's a bunch of just sort of SBK along the limbal area because there was no clearance. And you can't see the rest of the cornea, but this was happening circumferentially. So we have to continue to redesign her lens to be able to make it more appropriate so it clears this area because you don't want to have issues in the limbal area. This area is super important with stem cell regeneration. So it's really important that there's good limbal clearance. Okay, so here's some solutions for when you have discomfort on insertion. One of them, make sure you want to eliminate bubbles. Ensure good and consistent insertion technique. That will help a lot. Make sure the lens is not moving much, if at all. Have good centration, and make sure there's adequate central and limbal clearance to start. And here's some solutions if it's discomfort due to as the day goes on. You want to make sure that there's good lens alignment, and you want to consider a back surface toric design rather than a spherical if you see that the lens is not landing evenly across the whole sclera. And you want to ensure adequate central and limbal clearance as well. You want to consider adding edge vaults or notches for ocular lesions like pinguiculas or pterygiums. And you want to also address ocular surface disease if you're seeing that present. Next big issue that you will often need to troubleshoot is post-lens fogging. This can be a challenge, and this is just showing you a photograph of it through an OCT. So this top photograph is showing where the saline layer is, and you can see here that there's no debris here in this area, so this looks really beautiful. Down here, you'll see a much bigger difference. So where this arrow is pointing in is also the saline layer, and you'll see that there's a ton of debris here. And someone who has this level, if you see this on an OCT, will definitely complain, and it's something that needs to be addressed. Otherwise, they will have persistent issues. So here are some causes to post-lens fogging, and it could be multifactorial, and there's often not, I would say, like a particular reason why it forms. Every case can be different, why. But number one, you kind of want to look for ocular surface disease, and this could play into a role of why they get post-lens fogging. An ocular surface that has a ocular surface disease is going to have an unstable tear film. It's going to have inflammation on it. And if you have an eye that has inflammation, ocular surface disease, and you put a plastic device on their eye, even though it has saline, the eye still could get disrupted potentially with that. So it's important to address ocular surface disease and make modifications if needed. You also want to check for scleral lens alignment. This could also be very important, whether to help with tear exchange or reduce tear exchange if it could be excessive. It also could be due to just underlying inflammation from wearing the lens. It could be due to the saline reaction to the cornea. It could be due to the disruption to the normal tear film with this lens on. It's hard to say which one it is, but it could just be due to an inflammatory sort of process. It could also be due to corneal, excuse me, epithelial cell particulate accumulation. We know that the epithelial cells are sloughing off in a normal cornea. And where are these epithelial cells going? Are they leaving the saline reservoir? Are they not? Are they just accumulating? So, it might be hard to get rid of it, but this could be a reason why is that there's just this particulate of epithelial cells that's floating in that space where the saline is. And whether there's tear exchange, it could make it easier for these particulates to get out. If there's no tear exchange, it could be harder for these particulates to get out. It could also be due to a tight seal. So if the scleral lens is too tight, there may not be enough tear exchange, and you just might get debris accumulating in that saline component. It can also be due to cleaning regimen, and so sometimes people have different reactions to cleaning regimen, and so sometimes you might need to change the cleaning regimen to better address and try other formats to try to help. So here's some solutions to help address fogging, and you could try all of these or just kind of a few or one at a time. One is you want to address ocular surface disease. You want to ensure also that there's proper lens alignment 360. You can do something such as a tear uptake test with the vital dye, either using sodium fluorescein or lithium green to check for tear exchange. You also want to try considering different preservative-free saline solutions. You can also try adding 1 to 2 drops of a viscous preservative-free artificial tear into the lens bowl. I typically will recommend Celluvisc. So this can be valuable. So some people might react better to some preservative-free saline options. Some people will react well to just adding a viscous preservative-free drop. So you can try some of these solutions out. There's multiple different preservative-free saline options available for scleral lenses. We're going to actually go over that on the next slide. You also, the quickest thing you can do when you have a lot of post-lens fogging is just remove and reinsert. That will be the quickest way to fix it. Um, and then you also want to adjust the cleaning regimen. If someone is using a particular solution, you might maybe want to consider trying something else. Maybe try something that's preservative-free. So some patients might react better to some. So you can try switching the cleaning regimen if needed. You can also add fenestrations. This is, I think, pretty uncommon to do. For those that don't know what fenestrations are, it is literally drilling a hole into the scleral lens, and you need a special sort of drill bit to be able to do it. Sometimes your contact lens manufacturers might do it. You just have to potentially ask. But I would say this is not often used because you are then drilling into it, could break the lens. But typically the fenestrations are added along the limbal area. They're not done in the center because then the saline will kind of leak out. And you don't want the hole to be too big because then the saline's going to leak out. So you have to kind of be careful when you add fenestrations. And we'll actually show some fenestrations towards the end of the lecture. So this is a very busy slide, but I actually put this together before this talk to show you at least what I've seen that's available on the market. So these are all the available preservative-free saline options for scleral lenses. You're welcome to take a picture. You can also send me a message. I will put my contact information afterwards if you care to have this. It summarizes the different manufacturers, their trade names, their images of what they look like, and whether some of them have buffer solutions, additives, whether some are actually FDA approved for scleral lenses. You might be surprised that some of them may not have that FDA approval. So, and then also we'll go over different size options. And then the last thing is just knowing the replacement schedule for them. So I think this is a great summary to just have in your office, and you can kind of print this and or keep it as a digital sort of format. And hopefully this will be valuable to you. And then these are just different saline options. So if you have a patient that's having fogging issues, have them try potentially something else. See if they react better to it. So anyhow, this is just I think a nice slide to show all the saline options that are out there. The next issue is vision blur. And this can be very frustrating because we work so hard to design a very good lens. And then when you feel like this lens is perfect and you expect it to work like, amazing to really transform their vision, and then you get them to look like this. You see shadowing, ghosting, their vision is suboptimal. And this could be really frustrating. And it's like, what am I doing wrong? So this can present as a complication when you certainly fit scleral lenses. This has certainly happened to me and scratched my head multiple times why the vision is not good. So, but this will be something that you'll come across. So here's some common issues with vision blur. Number one, it could be just an air bubble. So if a patient puts them in, it's immediately blurry. Well, check for an air bubble because that will interfere with the vision. Could be due to residual cylinder flexure as well. Could be also the front surface of the lens is getting very dry and has deposits on it that will disrupt the clarity of the lens. Could be due to post-lens fogging as well. That will certainly impact the quality of their vision. Could actually due to be corneal edema. There's been reports that with patients with scleral lenses, people can, it's uncommon, but they can develop corneal edema, and that can certainly create clouding in their vision. Could also due to be higher order aberrations. This can be very hard to detect if you don't have some type of advanced aberrometer to look for this. And some of us may not have access to it, so it's hard to check for this, but this certainly can be an issue. Here are some causes for residual cylinder. It could actually be lenticular, something we can't really control. Could be due to the saline and tear lens power. We know that there's a saline reservoir in this lens, and this is actually creating some refractive index. And so it could be due to this. And we really don't have a ton of control other than adjusting the central clearance, but we don't have a ton of control of adjusting that power. It could be due to flexure. Also could do be higher order operations, and you could have some irregular astigmatism that's coming through the scleral lens when you add the lenticular component, the saline component, the corneal component, the tear film component. So there's a lot of components that could create this higher order operation. So I typically will suspect this when the VA is suboptimal despite a good fit, or the VA doesn't improve with the toric over refraction. So. And residual sill typically is when you have 0.75 diopters or more of astigmatism. You can't calculate the tear lens power with scleral lenses like an RGP. At least I could be wrong, but I found that there is no clear relationship between volt and power, unlike an RGP where there is a relationship between base curve and power because RGPs are fade off base curve and scleral lenses are not as much. They're fit based on volt. And I haven't really found a relationship between volt and refractive power. Maybe one day we might, but I haven't found that relationship yet. If you do, I would love to know. Okay, here's some causes for flexure, and really the only way to identify flexure is by doing keratometry or topography over a scleral lens. And if the Ks match the astigmatism on your over-refraction, then that usually leads to flexure. And the scleral shape does not always correlate with corneal shape, and you cannot predict flexure based off corneal toricity. This is what flexure looks like. One lens obviously on the left. This is a very bent lens, and this is what flexure will looks like. You can imagine the tear lens power of this lens being different than the tear lens power of this. So this is why you can get some vision blur when you have a lens that's acting like this when it's on the eye. But just a cool image to show flexure. Okay, here's some solutions to vision blur. And then you want to just add over-refraction or a spherical cylinder over-refraction. You want to consider increase the thickness by 0.1 or zero point 0.2 millimeters to help reduce flexure. You can try to improve surface wetting, address post-lens fogging, and add higher order aberration correction if you have that technology available. Next common issue is surface deposits. And I feel like I have about 5 minutes left, so I might try to run through these so I can get towards the end of the lecture. But there's multiple issues that can happen. It could be due to ocular surface disease, material compatibility, material wettability, poor compliance with the lenses, or just makeup and mascara. It could be that too. So, and here's some solutions for it. You want to consider changing the lens materials to a low wetting angle. And low wetting angles, the tears will spread easily across the lens and provide better comfort. So hopefully it just has less deposits form. And then you want to try changing the cleaning regimen. You can try alternative multi-purpose solutions. You can consider rubbing your lenses to help reduce the deposits. You can also consider adding tangible hydropeg coating, which we'll go over in the next slide. And you can use several RGB cleaners out there. I'm not going to go over all of these, but you're welcome to take a picture if you wish to know these. These are just a handful of ones that are available on the market. So for those that don't know tangible hydropeg, this is a technology where it's a coating that's applied to the surface of the lens, and it helps to improve comfort, improve wettability, reduce deposits, and help resist fogging. For those who don't really know that what hydropeg stands for, I kind of just looked this up to kind of better idea what this means. Hydra stands for water attracting, and then peg stands for polyethyl glycol. It's essentially a polymer of where it helps to reduce all these sorts of issues that we might have with scleral lens fittings. And this is kind of an example of what it can do. So on the photograph on the left, you have a tear film, lipid layer on the front, aqueous layer, mucin layer. When you put a lens that's uncoated, it could disrupt the tear film. And then with tangible hydropeg, because the coating can mimic the tear film, it helps to create a more uniform tear film layer when you're wearing the lens, and that's kind of how it kind of works. Oh, let me go back. And to keep the hydropeg coating, extend the life of it, you can consider a product called Tangible Boost. It just helps essentially to add more PEG or polyethylene glycol back into the mix because it potentially can wear off with use. And so this can help just extend the life of the hydropeg coating. So we're gonna probably skip this poll question just because we're getting close to time and I do want to lead to having people ask any questions. So essentially, I was going to go over what solutions are not compatible with hydropeg coatings, but I'm going to just show you right now. So there are 4 cleaning solutions in the US that are compatible with hydropeg coatings. It's essentially these 4. It's Unique pH, Clear Care, Boston Simplus, and Tangible Clean. One other problem that you might run into is prolapse. And essentially, it's where the conjunctiva gets pulled underneath the scleral lens, and you'll see a little bit here. And it's usually due to negative pressure created under the lens, and the conjunctival is pulled into the corneal tissue. It's often observed in the inferior quadrant most often, and the peak of the prolapse happens the longer the lens is settling. Generally, it's not a big concern. If significant, the conjunctival tissue can adhere to the cornea and can lead to vascularization and scarring, so you do want to keep an eye on it, make modifications if necessary. It may not go away despite a well-fit lens. You just want to try to optimize vault. Excessive vaulting centrally or over the limbus can create space for the conjunctiva to migrate under the lens, so you just don't want to have too much excessive vault. You want to modify peripheral curves or choose a smaller lens diameter. So I will skip this poll question because we're running just at 50 minutes. But the last thing I was going to run through is corneal edema. This is a rare but could be dangerous side effect of wearing scleral lenses. So you kind of want to be a lookout on it. This is what it looks like on OCT. And typically it's caused by hypoxia by 3 ways due to excessive lens clearance, lens thickness being too big, or an inadequate decay. Also could happen due to a tight scleral lens. And usually there's been some reports that the IOP could actually increase when you see signs of corneal edema from scleral lenses. So you want to check the IOP if you are suspicious of this. It also could be due to a dysfunctional corneal endothelium. And just remember DK over T. DK stands for oxygen permeability. T stands for thickness. You want to do really anything that improves the oxygen transmissibility. So you can either move to increasing the DK or decreasing the thickness. And these are some steps to reduce hypoxia. It's increasing the DK, so more than ideally 150. You also want to minimize excessive saline clearance. And that's why saline clearance is important because the more saline there is, oxygen transmissibility goes down. So you want the central clearance to be ideally 250 microns or less. You want the limbal clearance to be 100 microns or less. And you want to consider reducing lens thickness between 2 to 300 microns, the less around that range, the better. You can add hypertonic saline solution to help reduce the corneal edema. I'll show you a quick video of fenestrations. We're pretty much, I think, at 50 minutes. So this is a short video. It'll show you.
Dr. Paymaun, after
Yes.
this video, we might go to questions. We only have 5 minutes left.
Okay.
We end around 8:30, but I would love to watch the video first.
Okay. So I'll show this here. I'm gonna might open up to the web here. Okay. So this will show you a fenestration. Yeah, and then they're just rounding the edge of the hole with it. All right, back to my lecture. Okay. Otherwise, they're placed around the limbal area, but that I think is it. So I just would thank you so much for your time. I know all of you are busy and appreciate you taking the time out of your end of your day to listen to me and just and my lecture. And so I'm really humbled to do this, and I appreciate all of you and the Scleral Lens Society for giving me this opportunity.